Thanks everybody for coming. First things first, what's first? Security first. As you may have heard in my lightning talk or in e-patient Dave's lightning talk, I have type 1 diabetes. And usually that causes my blood glucose to go up when I give public presentations. However, this time is different for some reason. I've been popping my emergency glucose pills all morning, but it seems nothing gets to digest. Even the stroop waffles didn't work. So my blood glucose is currently a bit on the low side, and if I collapse, I hope there's some medical professionals around. I'll try to keep this, but if I start talking nonsense, please wave your hand and I'll pay attention. So, this talk is about patient-generated health data and consent, and especially in the context of this Kanta project that we have in Finland. So that's a centralized healthcare data repository, and there's the medical part and a PHR part, and there's one user interface for patients, so kind of portal. And what my talk is more about is on the PHR side. And the PHR, when I've been discussing with people during this conference and before, people have different ideas on what PHR might happen or might mean. So in US, it's usually you've got a patient portal and you can download your own medical record. And that downloaded medical record is your personal health record. In MedMay in Netherlands, it's something more, so you can get organizations to actually change your medical record between themselves. And then there's the third aspect, that's the PHR as Apple Health, for instance, on your phone. So that may contain your medical record, but it also contains plenty of other data. Your heart rate, your step count, your blood pressure readings, your nutrition data, and so on. So that's the patient-generated data I'll be talking about. And that's also the view for Kanta PHR. So that's mainly concerned with the data that we all gather with our different devices. And it may include the medical data, but that's not the main part. So as I mentioned, the Kanta system is divided in two parts. There's the medical part on your left, and then there's the wellness part, so to say, so the patient-controlled part. And medical professionals and medical institutions use the medical part, and they might use the data from PHR as well, and vice versa. But the control is still medical for medical and personal for personal. And Kanta PHR that you can find in Zulip, in channel Finnish PHR, with mixed languages. We sometimes speak English, sometimes Finnish. It's a government initiative. It's been running for many years already. And it's especially currently for this patient-generated data. We have discussions on whether we can copy our own data from the medical side to this PHR part. Not happening yet. There's legislation in Finland that says that yes, you need to give patients their own medical records, and there's legislation in Finland that says no, you're not allowed to give anyone access to their medical data in digital format. So you may get printouts from your hospital, but you can't currently get it to the Finnish PHR. The legislation is changing, but it will take a few months. And the PHR ecosystem is targeted on wellness apps. So all kind of different apps you can then connect to this PHR, and they may or may not be medical devices. So because the data in itself is not classified as medical data, also the apps don't need to be classified as medical devices. So if you want to track nutrition, weight, anything like that, you can, and it's a more lightweight process for those apps. And the platform is really aiming for wide ecosystem adoption. So I welcome all international companies to build apps on that too. And I actually would need some outsiders there because I have a hard time convincing the profiling people there that no, we don't want to make too strict or too Finnish-centric profiles, rather we want to have profiles that allow this interoperability of apps between different ecosystems. And of course, the platform is based on FHIR. And my own company, SensorTrend, is building this app for type 1 diabetes on top of the Kanta PHR. So what I'll mostly be talking about today is the consent that's required when the medical professional asks me, for instance, for my data from my PHR. There are plenty of other consents in play as well, so I need to give consent to the medical part of Kanta for different organizations to see my data there. So all the medical institutions in Finland are required to store my data into the Kanta, but they are not allowed to read it from other organizations unless I give consent. That's a different talk. I won't be talking about that. And then, of course, also this, can I get my data to Kanta PHR, might require consent and so on. But this is what we talk about. And even before the consent resource, how many of you are familiar with OAuth? OAuth. 95%, so I won't get into details, I thought so. So we use that extensively in all of the apps. So when you log in to our app, for instance, you can choose Facebook login or Google login, and that uses OAuth. Okay, can SensorTrend now get your email address from this account? And yes, you kind of give consent. And we also have plenty of different data sources, Google Fit, for instance. When we add that as a data source to SensorTrend's application, that's again OAuth. Do you consent SensorTrend to access your Google Fit data? And then the Kanta PHR has a smart on FHIR-like authentication process as well. So I'll go through this real quick. This is in Finnish, by the way, all the screenshots, but we'll present that, okay, this is Google Fit, and then you get to choose your account. And then Google presents, okay, these are the data that SensorTrend wants to access, and then you can get details, okay, what does it mean that I share my nutrition data, and what does it mean if I share my location data, and what does it mean if I share my training data. And then if I consent, I get Google Fit added as a data source to our service. And then I can see some neat graphs. So that's the essence of our service. We create different graphs that help people make sense of all this data. And all of that includes plenty of consenting, but not consents as resources. So what actually did happen just now, or when I took the screenshots, is that we didn't get any data when we did the authorization part. We just got the access token. And we don't store that as a consent currently. We store the access token, and that's good enough for us. We know that, okay, we have this access token, and we can validate that against Google's services. This is still valid. Okay, as long as it's valid, we know that we have the permission to access that data. And we don't store any of Google Fit data in our services, so we fetch it from their services on demand whenever we need. That's kind of controversial for some dinosaurs, but nowadays the internet is so fast that our server can access Google servers and transfer data in about the same time as it would take for us to fetch it from our own database. So we don't store that as a consent. You probably could if you wanted to, but we don't. So going on to the consent resource. This came up on Zulip chat a few days ago. I thought about should I cancel my presentation entirely, because that's based on R3. And then there we have these consent state codes, and they are draft proposed, active rejected, inactive entered in error. And R4 doesn't have those. Rather, it's mixed between this event status codes, and those are different. And someone else did ask about that, and someone else did reply that, okay, this mapping is still a work in progress. We are not entirely sure what that means. So I thought about this, and I thought that, okay, I'll give this presentation anyway, and it might serve as a feedback in that process. So we can at least show how we use the consent resource. So now I'll describe a scenario from Smart on FHIR launch to the consent. So that kind of a graph. Yeah, messed up. I was making a really nice presentation, synced presentation, should have gone in different order. But anyway, first we check that, do we know the calling party, the ISS, the issuer parameter in the launch request. And if we don't know the server, we'll present the practitioner with a note saying that, hey, you're not provisioned in our system. Please contact our sales team and we'll make it happen to you. And we probably could do that in different ways as well. We could auto-provision our app and give them trial access for 1 month and so on. But there are some contractual issues. So if we know the issuer, then we check, do we know the patient? And if you don't know the patient, we need to ask the practitioner to create a login link. I'll probably just go on like this and explain it with screenshots. So now we don't know the patient, and we explain to the practitioner that this patient, we get the name from the FHIR server that's issued the launch. And we say that, hey, this Team Smart has not given you consent to watch their data and actually even contact them, because we don't know how to contact that patient. But we can offer the practitioner to create a link and then send that link to the patient, because they have communication channel with the patient. So we propose, okay, take this kind of text and send that to Team Smart, and then they'll come up to our service. They might already be our user or might not, but we just don't have the link between that FHIR patient and some user that's logged into our system. So when we ask the practitioner to send that link and the user comes to our service, either logs in or signs up, we say that, hey, there's this consent request waiting for you. Select whether you want to access or deny that. And then the next part is, if we do know the patient, then we don't need to bother the practitioner with sending the link, because we already know the patient and we can do that for them. So then we can just offer a button, okay, press this button and we'll ask Bacon Ragsdale in this case for their consent. So the clinician presses the ask for consent button. And then what happens is that they need to wait for Bacon Ragsdale to actually approve that request. And so far the practitioner just sees that, okay, this has been requested. And that's one of the issues I'd like to discuss more about later on, is could there be a subscription for the EHR notification that, hey, now Bacon Ragsdale did give you authorization. Currently, we don't have that in place. And then if Bacon Ragsdale doesn't want to give you access to their data, then we just need to tell the practitioner that, sorry, they refused. And then the practitioner might try in other ways to persuade Bacon to, please, can you give me your data? And this is how it shows on my patient side view. So when I've logged in, I can see that I have given consent to this organization called Argonaut to view my data, and I can now withdraw that consent, and I can review the usage from our usage logs each time somebody accesses that data. Based on that consent, we can see that, okay, this consent has been used. And I can download a receipt, a Kantara consent receipt. That's a really geeky stuff, not in wide use yet, but some my data people like those kind of things that if you give your consent, then you get some kind of receipt, you have a wallet, you can keep all of those consents somewhere with you. Then there are other organizations, so Old Health Clinic, I have allowed that at some point, but I'm not a customer of theirs anymore, so I've said withdraw to them, and now I could still allow that if I wanted to, and I can see, okay, what was the time frame they used my data and so on. And then there's Good Health Clinic that just sent me the consent request, and I could either allow or deny that request. And then there's a Bad Health Clinic that has sent me a request in the past, and I've said deny, but I could still allow if they call me and say that, hey, we give you $1 million to access your precious type 1 diabetes data, then okay. So I guess I'm going way faster than I expected. I probably left something out unintentionally. Anyway, I want to advertise my data. So my data organization, global organization, was founded yesterday, just as we were heading to the party. So there was a global telco with hundreds of participants, and they set up this my data organization that's built on around the idea that we as citizens, individuals, should control our data and where it flows. Do sign up if you want to at least check it out. Related to that, there's these kind of things. So that's another service that's currently in Kanta PHR. It's made by a university hospital, and they view these things from a different perspective. So currently when I take their service into use, they give me these kind of terms saying that, okay, the data stored in the service is used for these purposes: arrangement, planning, implementation, follow-up, and quality management of patient examination and care, so basically whatever they do in the hospital. And then also, of course, for billing, and then practical healthcare planning statistic that might be nationwide or something, and scientific research. And I have no idea what kind of scientific research that is, and I have no further say about whether I like that university or that private company doing something with my data for scientific research. So they have their own ethical committees that take care of all this consenting for me. And some people appreciate that, my data people don't appreciate that. We want our own power. So what we do instead is give patients some choice. So when we onboard their own our app, we ask them with checkboxes, okay, how do you like your data to be used? For instance, only for your own treatment, or improving medical practices, or medical research, or other scientific research, or other purposes. And then we allow them to select always, which means that, okay, don't bother me with any additional questions, you're free to use the data. Or I can select upon specific request, which means that each time somebody wants to use my data, I want to know something more and then give a separate consent for that. So that's the my data view on consent. Should be fine-grained, and we think that this is also more aligned with GDPR that says that yes, you need to ask for consent for specific purpose. I'm not totally out of slides. I have some backup slides there, but now would be a good time for questions. Then I have this first question. Did anybody understand everything or anything? Was I blabbering? Was I speaking Dutch?
No.
Okay. Yes.
I have the mic, sorry. And you're certainly not speaking Dutch. But could you tell a bit more about my data? So how did it initiate, who's behind it, those kind of things? What kind of traction can I expect of this platform?
So I've been involved in some Facebook groups where this has been discussed since 2011, I guess. And then there has been My Data organization in Finland since 2014. And we've had My Data conferences for 3 consecutive years in Helsinki and Tallinn. And there was increasing interest from international parties, and that's why we wanted to set up a truly global organization. And there are private companies, individuals, and government entities, or let's say public sector representatives, and the board was just selected, and we wanted to make it so that it represents all of these entities and their different ideas. And I'm sure that MyData.org is much better in explaining the goals and so on. Do check it out, but it's many parties are involved in forming that platform.
Hi, I had another question about mydata.org. I noticed on the last slide there was no option for never.
Yeah, you don't necessarily need the option for never. My interpretation would be that if you don't select either of those, that means never.
Okay.
It's another radio button, it's a checkbox. Good question. We may come back to this design and explain it in more detail.
Hi, Michael. Thanks for this. Have you guys looked at the consent resource?
Yes.
Are you using it?
We are, internally.
Right.
So we are not sharing it. Did you watch my presentation from the start?
No, I didn't. I admit to walking in late, sorry.
Right. So I did this, and I did this first. So we did this check this week, or was it last week, that there is consent resource in version 3 and version 4, and we don't currently know the mappings, but then I explained how we actually use it. So what are you can see the draft, proposed, rejected, active states there, and so on.
I'll do the mappings next week then.
Excellent. Yes, what I did forget to mention was that the consent resource is currently in maturity level 1, so not widely used, but we're getting there. There's one back behind. Okay.
Okay, I think the concerns what you have are too generic, because it also depends like what kind of data you want to share, because I think there's also law says you should only share what app is requiring. So I often hear this question like, if patient resource has 10 fees while the app is showing only 5, you're not allowed by law to share. So if you just say share my data, it is too generic.
Yes, that's a very good point, and that we have discussed extensively. So how much do we actually want to bother the individual with the consent? So when I showed the Google Fit consent, for instance, there they have some kind of granularity. I can select whether I want to share my location data, my nutrition data, my physical data, and so on. So that is what we are discussing. Whenever you connect our service to the Kanta PHR, for instance, there is this consent process. I might have a slide for that somewhere. No, I didn't. And now I ended the presentation. Anyway, there I need to say that, okay, SensorTrend app is allowed to access these resource types from your Kanta PHR. So we already have that selection there. And then we have been thinking about whether we should do that again. And we think that if you are concerned about that, then you probably in our consent screens select that ask me each time. And then once we ask you each time, okay, now for this purpose, we would like to use your this and this and this data. Is that okay? Or if that's not okay, we have another alternative. Can we have at least this data for this purpose? So we have reserved that granularity for a later part because it's really hard to generalize.
But in this form, you're still not compliant with law, right? Because this is too generic.
Which law?
What's your take on the primary first-line medical care concerning a override by a physician when a patient comes into the ER and they want to access, and the patient have, for example, selected specify on each request while they are unconscious. They pull the wallet, they get the ID. What about the possibility to an override by a physician? What's your take on that?
Yeah, excellent question. There are different approaches, this break the glass stuff. I think in medical side of Kanta, it's quite justified that the medical professionals have the possibility in emergency situation to go there and read the data. I'm not so sure about the PHR part though, because I would actually be worried if some doctor in an emergency situation would go into my PHR, take that data and rely on that, because it might be just fake data that I used for some app and so on. So I do think that's a really good thing when you're working with medical data. When you're working with PHR, I don't see the need, and I also see some difficulties. Thanks for the question.
Okay, I have a question. You have talked a lot about consent between a patient and various organizations. Have you been working with giving that consent further on to your next of kin, your spouse, and other private persons that help you?
I think I got the question, but I'm not sure. Can you please return the mic? So the consent, you mean, do I want to give consent for some medical professional to access my child's data, or?
No, more like, well, if my wife is very sick and in the hospital and I need to help her doing stuff, so can I, through this, get access to data and actually be able to help her because I can get her diagnosis and stuff like that and start Googling?
I think that's again more about the medical data than the PHR data. Well, might be both. Of course, you can and you should do some kind of precautions. I have some, so I know how people can get access to my private data. I have an identical twin brother, and if we're not in the same plane crash, then he can access my data. Also my GitHub data and so on, to make that public source. So that's different topic. I don't see how that directly maps to consent, but good question.
On the screenshot where you were showing a list of current consents to the individual patient, here are the places that have access to your data, here's a button to withdraw, and so forth. There was an option to review usage
Yes.
for each consent. And I'm just wondering, is that usage based on like a health provider running your SensoTrend app inside the EHR, or is there also API access that gets made available, and is it API usage as well?
Right. So this review usage is just for reviewing our access log. So when we get a Smart on FHIR call, and we notice that yes, there is this consent that matches and it's active, so you are allowed to access the data, we record that, okay, this practitioner accessed your data at this point, and these were the main calls that they made. We also store all of that in like granular level. We don't store it, we don't show it, and in that. So what currently happens there, you get a HTML page, you can see it, but the API question is good. That HTML page, of course, uses an API to fetch that data, and we could.
Sure, but the interface that providers get to use is your app, your sort of Smart on FHIR app that embeds in their EHR. They don't have another way to access the data.
Yeah, they don't get raw data. They get the data through our app on screens, and yeah.
Thank you.
And that brings me to another good question, and that's the PHR versus medical data. So when they do access the data, and they do make some clinical decisions based on that, my diabetes data, they of course want to have some storage of that. And we have been discussing whether they should get the raw data. And I don't see the need for them to access the raw data. I see much more need for them to access the graphs that they actually inspected when they made the medical decisions, so they can capture those screens that they did watch, or that's their EHR. The other use for raw data in medical domain is the statistical and triage and that kind of use. So we may share that data. That's yeah. This improving medical practices data. So for that kind of purpose, the clinic might want to see that, okay, right now Mikael seems to be doing quite fine. He had a low blood sugar in Amsterdam, but okay, we'll take that as nothing serious happened. His lab results are okay, we can see it down systems. His own treatment data shows that he is quite well balanced, not optimal, but good. So we'll keep Mikael in this digital care plan. We don't bother him, we don't bother our own staff, we don't invite him to visit us. We just put him in digital path. But then when they make a check in 3 weeks or so and see that, okay, now Mikael's blood glucose has been going really wild, they can send me a notification that, hey, can you please come and discuss with the nurse, for instance. So for that, it's really good that that's analysis done by an algorithm, and for that they need raw data too. Yep.
What's your view on enforcing the consent access and the provenance of it, how it flows further on? Somebody got consent to access the data. How do you make sure it's not copied offline somewhere else, distributed for research purposes?
Right. We are not there yet. So we store the dates when the consent was given, and we currently use that internally only. So once we start distributing these, and once it usually goes with the data, but if somebody would, let's say, fake a consent, they wouldn't necessarily be able to do anything with that, because they would then also get access to our systems or other systems to get their data too. So just forging the consent currently is not a bad thing, but yes, I agree, provenance is need it at some point, and especially going forward if we allow medical companies to access that data and so on, so we need better documentation.
Thank you.
All right, I just saw the 5-minute mark from there, so there are 5 more minutes. Thank you for the questions. Well, there's more.
Just one thought then, that maybe in the future a doctor will prescribe your app.
Yes.
So whose data is it then?
We are expecting that. So business models for healthcare apps have been really tricky. But yes, subscribing an app, I would say still my data principles should be followed. It's much better for the doctor to be transparent and, let's say, cooperative when discussing, okay, can we use your data? And if somebody has something to hide, they might say that, no, we just need your data, without justifying it. And that gives the immediate response that, no, I don't want to give you my data. But if you are careful enough to say that, okay, we need your data for this purpose and for these reasons, then most people will say that, yes, of course, you're my doctor, you take care of me, please have my data, please have even more.
But where should it end up in your Kanta system, in the PHR part or in the...
Yeah, so I would say in your data lake, probably. So in Finland, there is the Kanta system, the data would flow there as well, but if you need it, for instance, for these triage purposes and so on, it will stay in your systems. And we have this consent to allow all of that. And then if you don't want the people to have the choice, then you can just disable those checkboxes and pre-select them for them and don't allow them to change them. You're not satisfied with the answer. Challenge me.
Still, I think it's difficult to see. I mean, you have one solution where you have like one database for the providers and one PHR part. But maybe you could do it in another way, that you can mix them up and sort of keep track on where the data came from, and that way sort of handle the data differently.
Yes.
So then you don't have this like wall between.
Exactly. So I think the wall between is still required in Finland because of legislation. So there are different legal requirements for this medical data and for the patient-generated data. And we want to be sure that, okay, now this patient-generated data actually became medical data and needs to be treated a bit differently. So we do need the wall. On the other hand, I don't necessarily see the need for a storage for this PHR data. As I said, we don't store any of the Google Fit data ourselves. We don't push it to Kanta PHR. We like it just fine in Google's servers. And we trust that it will be stored there. And if we are nice with our users, they continue to give us the access there. So that's one part of that. Don't need to store all data in different places. You could just say that here's the origin of the data and let's fetch it from there.
A small question. Can you tell something about how many people are actually already gave their consent, or some numbers?
No.
Nobody did?
No, I can't. Oh. No, the main reason is that we are not operational yet. So the other app I referred to that is operational in Kanta PHR. We are currently in beta phase, so to say. We'll find out in January or at latest March or March next year or the year after that. It's a public project, so. But yes, we have been doing these kind of studies in our Facebook user groups. We have proposed that, okay, if we ask for your consent in this way, would you allow it? If we ask in this way, what would your reaction be? And 95% of the respondents says that my treatment always improved medical practices. 20% say that upon specific request. 80% say always. Medical research about the same, 80-20. Other scientific research the other way around. 30% say always. 70% upon specific request. Other purposes, 95% say upon specific request, and the rest either both or none. But small user group, so that's less than 100 people we go these things with, so might give you some view, but not scientific proof. All right, now I say thank you, and you can applaud.